we're going to be talking about polycystic kidney disease. So our objectives, we're going to be differentiating between the two types of polycystic kidney disease, which is autosomal dominant and autosomal recessive. We're going to mainly focus on the autosomal dominant because it's more common in adults. So we're going to be identifying assessment findings, lab tests, manifestations, treatments. We're going to be talking about the nursing diagnoses we'll see and the goals that we should set for our patients. And then we're going to identify crisis situations and geriatric considerations for the disease.
So here's an explanation of the two. As Sara said, autosomal dominant is far more common and it's seen in adults. So we're going to mainly talk about that, but we also wanted to point out some things about autosomal recessive as well. So autosomal dominant has an age of onset between 30 and 40. It's caused by a mutation in the polycystin 1 gene or the polycystin 2 gene. The polycystin 1 or PKD1 attributes to about 85% of the cases, whereas polycystin 2 attributes to about 15% of the cases. The patho behind autosomal dominant relates to the cyst basically taking over normal functioning renal tissue or replacing it. They increase in size over time. Then they fill the renal cortex and medulla with these cysts. And then the cysts can also develop in the liver, pancreas, and spleen, which can cause further complications that we'll talk about later on. For autosomal recessive, this is exclusively in neonates and it's very rare. At birth, they rapidly progress into renal failure. About 30 to 50% of the newborns die shortly after birth. If they do survive, the prognosis is good, but they will almost 100% of the time need a renal transplant. This is caused by a mutation in the PKHD1 gene, which codes for fibrocystin. The patho is similar, but the cysts ultimately develop mainly in the renal ducts, but they can also develop in the biliary and exocrine ducts as well. And like I said, they rapidly progress into renal failure, and the prognosis is normally not good. This is just a slide that kind of mentions everything that I talked about previously. If you want to pause it here, this is a good summary as well. So the manifestations of autosomal dominant, they're often asymptomatic until about the age of 30 to 40. This is because your kidneys can really function until they're almost completely run out of functioning tissue. It's like 25%, I believe. So when they do have the symptoms, it presents as back, flank, and abdominal pain that is extremely severe in most cases. Then the most common symptoms include headache, hypertension, hematuria, and then frequent UTIs. Later on in the disease, as it develops, they can go into chronic renal disease, which is less than 25% function, and then ultimately they will develop severe hypertension, anemia, metabolic acidosis, hyperkalemia, salt and water retention, and then like high phosphorus and low calcium as well.
Okay, so some abnormal lab results that we're going to be talking about. We're mainly focusing on kidney function, but we'll also see liver changes and electrolyte changes when the disease kind of progresses on. So for kidney, you're going to have a decreased GFR, or the glomerular filtration rate. You can have an increased BUN, increased serum creatinine. Like I said, your liver function test will be off usually later on in the disease. So, for example, your serum albumin levels may be low, and this is from you're losing so much protein in your urine, from malnutrition, you're not getting all the nutrients you need, and then you also have just decreased hepatic synthesis, your liver's not functioning well. For UA studies, you're going to be seeing, like Erik said, you'll see hematuria. It can or cannot be present. It kind of just depends on the patient. It is more common in the autosomal dominant disease. Proteinuria, so you'll have the protein in your urine, like we already said. Pyuria, which is pus in your urine you can have. And then azotemia may be present. And that just means that you have abnormally high levels of nitrogen-containing compounds like urea, creatinine, body waste compounds in the blood, and that's just from your kidneys not being able to filter out everything like they should be doing. And then for the autosomal recessive polycystic kidney disease, the major difference is they'll have the increased maternal alpha fetoprotein. Righty. So next, our nursing diagnoses. I won't go through every single thing, but I'm just going to point out our main one is the ineffective tissue perfusion, and this is more related to like the impaired excretion of those waste products that we talked about in the labs by the bloodstream. So you can have like the increased BUN, increased creatinine, hematuria. You can also see the acute pain, like Erik said, you'll have the flank pain, the abdominal pain. Imbalanced nutrition, less than body requirements. That's also related to your electrolyte imbalances can be off. Impaired urinary elimination, and then excess fluid volume. For your short-term goal, the patient will eat 3 low sodium, low protein, well-balanced meals to help the kidneys filter products and maintain fluid balance during my shift. And then for a long-term goal, you'll have the patient will maintain within his or her normal lab values by maintaining compliance with medications and diet to help with renal perfusion by next checkup.
Okay, so the treatments and medications, this is for the autosomal dominant mainly. The diet modifications, so these patients are going to have problems with excessive salt. They may have excessive protein or they may have low protein in their blood. So you really have to watch that and then link your treatments based off of that. So if they have high protein, you're going to reduce it. If they have low, you're probably going to give them albumin if it's low enough. The meds to control the main symptom of hypertension include ACE inhibitors, angiotensin receptor blockers, beta blockers, and diuretics. They all work differently, but they're all mainly focused on controlling that hypertension. And then also patients will have frequent urinary tract infections and or infections in the cysts. So for this, you normally give ciprofloxacin and or Bactrim. Previously, I also mentioned that they're going to have severe flank and back pain, so you're going to try to treat this with acetaminophen as analgesic therapy. And then late in the disease, they're most likely going to require a kidney removal and or transplant, and then dialysis when it gets into end-stage renal disease. For pediatrics, their manifestations are really just severe onset renal failure. You could actually feel the flank masses because they're so small. You could feel the cysts. They're going to have impaired breathing from the pressure on the diaphragm, and then they'll have liver fibrosis that also is linked to portal hypertension. So for those patients, for the neonates, you want to vent them right at birth, just to try to give yourself some time. And then almost always they're going to need a transplant before the age of 10 because even the medications won't correct the disease. The transplant's the ultimate correction for it.
Okay, so we have some holistic treatments that are mainly related to the patient. Like we said, they're not getting enough of the nutrients they need. So they might have electrolyte imbalances. Usually it's like potassium and phosphorus significantly that are off. So these holistic treatments focus mainly on trying to balance potassium, phosphorus, and other electrolytes. So we have American ginseng, milk thistle, feverfew, and kelp. The purple one is the milk thistle, the white one is the feverfew, and the brown one is the American ginseng.
So crisis situations for PKD, the most serious is intracranial aneurysm, and this is related to the poorly controlled hypertension of the patient. This leads to a hemorrhagic stroke and requires immediate intervention to try to help stop this. The most common complication is end-stage renal disease that requires dialysis, and dialysis is really the only thing that you can do with that, whether it be peritoneal dialysis or the other one if needed. Then lastly, they can also develop polycystic disease in their liver, spleen, and or pancreas, as I mentioned earlier. So the treatment for this kind of depends on where it's at for the organ. In the liver, you might try to repair some of the biliary tracts. The spleen, you might remove it. The pancreas, they might be put on medications, but ultimately this can cause further problems in various organs around the body.
Okay, so for some geriatric considerations, just one that I want to point out, your elderly patients are very commonly put on dialysis when their kidney function's very low. So just specifically for elderly patients, we need to be courteous about how a lot of them don't live at home. They have to live in inpatient rehabilitation centers or long-term care, so like nursing home. So we have to worry about how this is going to be affecting their daily life because dialysis is several times a week usually. So they need someone, or the nursing home will have to take them several times a week, and it's just affecting their quality of life, and it limits how much they're able to participate in the nursing homes activities and stuff. So we just have to kind of look at it holistically.
As well, not only related to their decreased thirst mechanism, they can have severe dehydration, but which can ultimately lead to severe fluid and electrolyte imbalances. The electrolytes are mainly focused at the disease in the kidneys themselves, but their potassium and their phosphorus are going to be off. Normally they're elevated and then your calcium is low in your blood, but these can kind of fluctuate depending on what point in the disease you're at. For the drugs themselves that we just mentioned, they're going to be metabolized slower in geriatrics, so you have to watch that, watch their levels, make sure that they're therapeutic. And then related to the low calcium levels from the high phosphorus levels, they're going to have decreased bone density because when your body detects low blood calcium, parathyroid hormone is released, and PTH breaks down bones, and so that can actually lead to a decreased bone density and ultimately osteoporosis in geriatrics. And then they can have development of other comorbidities, severe hypertension, and then they can have chronic UTIs with detectable kidney damage, and then also the damage to the ducts and the other organs that I mentioned in the previous slide.
Okay, so this is our concept map. I'm not going to go directly over every single thing just because we talked about most of it. For the medical diagnosis, I mainly focus on the autosomal dominant just because it's what we see more often and what patients we would be taking care of at this stage in our education. Okay, so our first NCLEX question. A 50-year-old female patient with PKD is being discharged. Which of the following statements by the patient indicates a need for further teaching by the nurse? I will take my antibiotics until all the pills are gone. I can eat all the cold cut sandwiches I want. I will monitor my urine occurrences at home. I will call 911 if I have a throbbing headache and a stiff neck.
So this is B. I can eat all the cold cut sandwiches I want, which is in relation to them having to watch their sodium, and cold cut sandwiches are very, very high in sodium normally, so they cannot eat all the cold cuts that they want. Next question is a 60-year-old female patient with developed PKD presents to the emergency department. Which of the following statements is the nurse's priority? A, my head and neck are very stiff. B, I would rate my back pain a 3 out of 10. C, I've been having some pain with urination. And D, I haven't had a bowel movement in 24 hours. So this answer is A, because of the severe complication of intracranial aneurysm related to hemorrhagic stroke. These patients are going to present with a very stiff head and neck and a throbbing headache as well.
Okay, so question 3. A 60-year-old patient presents to the emergency room with a throbbing headache and nuchal rigidity with sudden onset. What action should the nurse perform first? Instill contact precautions for the patient in a private room. Administer thrombolytic therapy as ordered to the patient. Assess the patient's vital signs and level of consciousness. Place the patient into reverse Trendelenburg position. So the answer for this one is going to be C. We definitely want to assess our patient first before we do anything else. We are most likely going to have to prepare them for a CT scan. And we definitely don't want to administer thrombolytic therapy. If Erik said, like, these are signs of a hemorrhagic stroke and whatnot. So thrombolytic therapy would definitely be not a good idea.
Yeah, definitely contraindicated. A 35-year-old patient recently diagnosed with PKD asked the nurse why she has developed the disease. What is the most accurate response by the nurse? A. Excessive alcohol consumption has a direct causation to PKD. The fibrocystin gene mutation leads to renal cyst development. Let's call the doctor to see if he can tell us. And D. A gene mutation in polycystin 1 or 2 leads to renal cyst development. So for this patient, since they're newly diagnosed between the age of 30 and 40, they're going to have autosomal dominant, and this is caused by a mutation in polycystin 1 or 2, and then you're not just going to call the doctor and ignore the patient's question. So you want to be educated and professional with the patient as always.
Okay, and last question. Which of the following are true about the major differences between autosomal dominant and autosomal recessive polycystic kidney disease? Select all that apply. So the autosomal recessive happens in neonates and is far more common. Cysts are mainly found in renal ducts for autosomal recessive. Mutation of polycystin 1 is a more common cause of autosomal dominant than mutation of polycystin 2. Cysts remain the same size over time, and then both autosomal dominant and autosomal recessive may result in a kidney transplant. So the correct answers for this one are B, C, and E. So although for the first one, autosomal recessive, it does happen usually in neonates, it is less common than the autosomal dominant, so that one's false. For autosomal recessive, that's true because it is usually found in the renal ducts. C is also true. Polycystin 1 is usually about 85% of cases, so that is more common, and that is true. Cysts remain the same size over time. They actually usually get bigger, so that is going to be false. And then, like we said, kidney transplant is usually the best treatment, so that is also true. And this is just our reference list.